Now I'd like to introduce our speaker, Dr. Samantha Baugh. Dr. Baugh is a pulmonary and critical care physician at Norton Healthcare, where she serves as medical director for the intensive care unit, respiratory care, and pulmonary rehab. She did her internal medicine residency at Cooper University Hospital and completed her fellowship in pulmonary and critical care at the University of Rochester Medical Center. She is board certified in internal medicine, pulmonary disease, and critical care medicine. She serves as pulmonary consultant to the Kentucky Medical Board and holds fellowship designation with the American College of Chest as leader in clinical chest medicine. Welcome, Dr. Baugh.
Thank you for having me, and thank you everyone for joining me for this today. I'm going to share my screen. Can everyone see that?
Yes.
Okay, thank you. So today I'm going to be discussing the role of advanced bronchoscopy in the evaluation of pulmonary lesions. It really should say pulmonary abnormalities, because just anything in the chest wall disease manifestations will be able to review a few of the common pulmonary diseases. These are my disclosures. And the learning objective really is to be able to formulate a differential diagnosis for patients that present in the general clinic, primary care setting with pulmonary clinical symptoms, and really just review some of the common radiographic findings that can be associated with some of those pulmonary diseases, and really just give you all the ability to gain some insight exactly what we're doing when we're taking these patients for a procedure to try to figure out their pulmonary disease. Okay, so this is case number 1, and the theme of the case, and this is how the patient presented to me. They said, "Doc, they keep telling me I have COVID." So this is a 43-year-old male. He has a history of hypertension. He's never smoked before, and he presents with shortness of breath. He said the shortness of breath began about 2 months ago. It's worse on exertion, as well as whenever he takes a deep breath, it gets worse. It improves whenever he stops doing what he's doing and rest. He also had a dry cough and lower extremity edema. So he didn't have any fevers, chills. No one around him was sick. He didn't have chest pain, no wheezing or chest tightness, and he doesn't have any history of COVID that he was aware of. So when you dig a little bit deeper, you find out that he hasn't had any changes in his weight or his vision, no joint pain or skin changes. He didn't have any symptoms of Raynaud's or changes in the color of his fingers, no pets in his home. He didn't use a humidifier. He didn't travel anywhere recently, and he was given a diuretic, but he really didn't find any great improvement in his symptoms with that. So as I mentioned, some of his history, you review his medications, and he's on hydrochlorothiazide. He lives in an apartment with his child and his wife. He socially drinks alcohol. He denied any drug use, no surgeries. He didn't really have any significant family history, and he works as a software engineer. So on exam, his BMI is 47, so he had an obese body stature. He's tachypnic, breathing at 24 times a minute, and his oxygen saturation is, I can't see that, it's low. On exam, he also has some lower extremity edema, no clubbing, and you walk him in your clinic, and he goes from 91% on room air, and he drops to 85% on exertion. And remember, this is a young guy. So this is his chest x-ray. And as you can see, it's largely abnormal. It has bilateral, just diffuse ground glass process, opacities, interstitial possible edema. And this is his CAT scan that he got done. And you can see here that this is too largely abnormal, but really it has ground glass bilateral changes, consolidative changes that you can see at, I can't find the pointer here, but that you can see sort of at the posterior aspects of the upper lobes of the lungs. And then you have this pattern on the right lung that almost looks like there's interlobar septal thickening, but it's actually a classic finding that we see in this disease pattern that the patient has, which we'll go through a little bit later. Okay, so our first question is, what is the next best step? A, referral to pulmonary for bronchoscopy. B, referral to thoracic surgery for surgical lung biopsy. C, trial of more aggressive diuresis. D, start antibiotics and steroids. Or E, repeat chest CT in 6 weeks.
So 100% chose A.
Oh, great. So it is A, it's referral to pulmonary for bronchoscopy, which is the theme of the talk, right? So the differential diagnosis for this case, you have someone who's relatively young with a bilateral interstitial process on both chest X-ray and chest CT. You got to think about, many possibilities. Could it be a viral pneumonia? Did he have COVID and just didn't even know it? And this is all sequela of COVID or some other type of viral pneumonitis? Could this be congestive heart failure? He's 43, he's obese, he has hypertension, possible sleep apnea. Could this be exacerbation of his heart failure? Could this be interstitial lung disease? Could it be a pneumonitis? Could it be from a medication that he's taking? There wasn't any medications on his list that are classic for drug-induced pneumonitis, but could it be a different type of pneumonitis, maybe from an allergic reaction like hypersensitivity pneumonitis? Or could it be diffuse alveolar hemorrhage, which is oftentimes can be associated with heart failure, but can also be associated with an autoimmune condition that may be undiagnosed? Okay, so how can bronchoscopy be helpful in the diagnostic workup of interstitial lung disease? And this is a busy slide, but there are many different types of interstitial lung diseases, several of them, and we kind of group them in different categories based on their etiology. There's idiopathic interstitial pneumonia. Those are your patients with idiopathic pulmonary fibrosis or nonspecific interstitial pneumonias, or your NSIP. There's also other types, COP or organizing pneumonia, DIP, RBILD, which is associated with smoking. That's respiratory bronchiolitis interstitial lung disease. Those are the patients are smoking. You get a CT scan, you see all these nodules, micronodules in the lungs. They stop smoking, it gets better. There's also autoimmune interstitial lung diseases. A lot of times patients with autoimmune conditions, they may have pulmonary manifestations of their interstitial lung or of their autoimmune condition before they have the systemic manifestations of their autoimmune condition. So that's something that always has to be on the differential. You have hypersensitivity pneumonias, granulomatous, that's your sarcoid, as well as other, which is the really rare things. So I hope I didn't lose a lot of you with that. I just wanted to make sure that you knew that there's a lot of different interstitial lung diseases, and really you just want to refer to pulmonary. Okay, so what did our patient have? He had pulmonary alveolar proteinosis, and you're probably like, Dr. Bob, what in the world is that? It's a very rare lung condition where it's caused by the abnormal buildup of surfactant in the alveoli, which interferes with gas exchange. Every single one of us has a normal amount of surfactant in our alveolar space, which actually helps with gas exchange. But these patients have an abnormally large response where they can't clear it, or they're producing it at rates that are really interfering with gas exchange. And that's where they get their symptoms, their dyspnea, their hypoxia, their fatigue. Okay, so I mentioned it was really rare. It happens in 7 in 1 million people. So I only had one case my entire pulmonary career. How do you get it? Well, you can get it. Most of the patients that present are autoimmune, and that's about 90% of the time it's going to be autoimmune. Secondary causes can be from like lymphomas or hematologic malignancies. Some people can be born with these abnormalities caused, and most of them actually present before the age of 10 years old. So when patients present, they're typically in their 2nd to 5th decade of life. Our patient was in his 40s, and it's strongly associated with smoking, although smoking doesn't cause it. What studies have found is that it's associated with smoking, and it's more common in males who are smokers when compared to females at a 2-to-1 ratio. And they didn't see much of that in patients who did not smoke. Okay, so these are the radiographic findings for pulmonary alveolar proteinosis. They call it crazy paving, where you almost see like, the tissue in the interstitium, and then there almost looks like normal lung in between is tissue around the lobar. And then you have just this, you can also have these consolidative changes here that you can see just diffusely around both upper and lower lobes of the lungs. So the treatment for PAP is whole lung lavage. And as you can see here, this is the alveoli. This is sort of like an alveolar sort of pattern, how you can see like the dense consolidated changes there. Whole lung lavage is essentially what this picture is, okay? So when my patient came to get his procedure done, he said, "Dr. Ba, are you going to power wash my lungs?" And I said, "Absolutely." So this is basically, we inject a whole bunch of saline in the lungs and we shock the alveoli and we get all that junk, that surfactant, the protein and fat content out of there. And this was his first liter. We did 9 liters in this patient of sterile saline into his lungs. So this was the fluid that we got back, which looks very abnormal. This is not like the regular alveolar fluid that we typically get back, which is mostly clear, maybe a little cloudy. This looks very pale. And as you can see, you have the sediment that goes at the bottom, and that's all the stuff that was in his alveoli, the protein and the fat. And this was after 9 liters of fluid. And as you can see, there was the first 2 liters, you can see that there's more of that substance at the bottom. And then once you get to the tail end of the procedure, you start to clear up. And this actually illustrates, it's pretty remarkable how this patient went from having a largely abnormal CT with impaired gas exchange to having a relatively normal CT after his whole lung lavage. Okay, so that's case 1. Case 2, I keep getting pneumonia. A lot of us hear this all the time in the primary care settings as well as in the pulmonary clinic. This is a gentleman I saw who had 6 episodes of pneumonia in the past year. He was a former 30-pack year smoker, retired from UPS, and he had shortness of breath, cough, and wheezing, and he always got better with steroids and antibiotics. But as soon as he stopped taking them, his symptoms came back within a few days. He has a history of hypertension, HFpEF, coronary artery disease. He was on some bronchodilators and antihypertensives. He lives in his house with his wife and his dog, no drug use. And he had a cabbage, and he was a former electrician. On exam, he was pretty much unremarkable, besides the fact that he had some rhonchi in his left upper and lower lungs, but otherwise he looked pretty well. And this was his CT scan. As you can see here, you have this calcified structure in the airway where the arrow is, and then on the mediastinal windows, you can see it there. It's the same color as the bone. And when you track down his left lower lung, you find that he has pneumonia there. So he has a lesion that looks calcified in his airway, and he has post-obstructive pneumonia. So this gentleman had a broncholith. Broncholithiasis is what we call it. And it's essentially calcified material within the trachobronchial tree. They originate from calcified peribronchial lymph nodes that actually erode into the airway. And these are some examples of that, as you can see in all these diagrams down below. And what happens is the broncholith blocks the airway so that the airway develops post-obstructive pneumonia distally, and patients typically get better when you give them antibiotics, but then it comes back because the airway cannot clear itself. So it's a setup for recurrent pneumonia. And here's another question. What is the most common cause of bronchiolithiasis? Is it A, sarcoidosis, B, histoplasmosis, C, erosion of calcified bronchial cartilage, D, in situ calcifications of aspirated foreign material, or E, cryptococcus?
One 100% responded D.
Okay, so in situ aspiration of foreign material. So the answer actually is B, histoplasmosis. These are all causes of bronchiolithiasis. Histoplasmosis by far is the most common cause of bronchiolithiasis, especially in this region of the country because of the Ohio Valley. So what can we do with bronchoscopy? Well, we can go in and take these things out and clean up the airway, as well as sort of help the airway heal a little bit better, because once this bronchiolith is removed out of the airway behind it is actually really, really inflamed, and a lot of granulation tissue forms. So we're able to treat that granulation tissue so that it can heal a little bit better. And this was a gentleman that I removed his bronchiolith, and it was huge. I actually had to take his ET tube out in order to get the bronchiolith out. But his episodes of pneumonia reduced, and he was sent on his way. All right, so this is case 3, the cough that just won't go away. And this is a 43-year-old female non-smoker who presents with a chronic cough. It's been going on for years and years and years, and she's coming to you for probably a second opinion. It occurs daily. There's no exacerbating or relieving symptoms. It's dry in nature. She has shortness of breath and wheezing, but she says she doesn't have any history of asthma. And as I mentioned, she was a non-smoker. So no medications. She lives in a house with her husband. Her basement is finished. She had a C-section in 2013, no pertinent family history, and she's a stay-at-home mom. On exam, she feels well, her lungs are clear, her SATs are 100%. There's no rashes, effusion, edema, no clubbing, so pretty much unremarkable physical exam. And she gets a chest x-ray, which was followed by a chest CT, which shows bulky hilar and mediastinal lymphadenopathy. And it's pointed here with the arrows. And you have to come up with a differential diagnosis for this. So you think, could it be sarcoidosis? She's a young female. She has mediastinal adenopathy. Could it be a pulmonary infection? Could it be histoplasmosis? Could it be lymphoma or a primary lung cancer or metastasis to the lymph nodes? Which of the following can cause mediastinal lymphadenopathy? Is it A, smoking, B, heart failure, C, pneumonia, D, ILD, or E, all the above?
One 100% voted for E.
Great, so everyone got it right. So all the above, these are all reasons that can cause mediastinal lymphadenopathy. So if you get a CAT scan and the radiologist is reading mediastinal lymphadenopathy and they're a smoker and that's all they see, it could just be from that. But that is certainly something that can cause some worry for patients. So it's always best to just refer those patients to pulmonary if it's not an obvious cause. So all the above. So our patient had sarcoidosis, which is a self-limiting to severe life-threatening multi-system inflammatory condition, and we really don't understand why it happens. It behaves very similarly to an autoimmune condition, but is not technically an autoimmune condition. It causes these non-necrotizing granulomas, or balls of inflammation is what I tell my patients, to form in various organ systems. So these granulomas can form in the brain, the lungs, the mediastinum, the lymphatic system, the skin, the liver, the spleen, the joints. So it's really important that if you do have a patient with mediastinal lymphadenopathy, you ask about these things. Do they have joint pains? Do they have new rashes? It affects all races and ethnic groups, but it's more common in African Americans, and it actually has a 3 times higher incidence, and it's more common in female African Americans. It has a peak incidence of about 20 to almost 40 years of age, but it typically is diagnosed when people are less than 50. It peaks in the 4th decade, as I mentioned, but the overall mortality is about 1 to 5%. And if you guys recognize this fellow, he was a comedian, Bernie Mac. He actually died from the complications of sarcoidosis. So it's just really important that you know these clinical manifestations and some of the complications that can happen from it. So when you're in your primary care setting, these are certain things that you may be able to pick up on physical exam. These are the cutaneous manifestations of sarcoidosis. The diagram here in the corner is the erythema nodosa, which can be in the lower extremity on the shin. You have lupus pernio, which is at the bottom, and this is usually asymptomatic. It gets worse in the winter months. It usually doesn't cause any itching or anything like that, but it can. Usually patients will just think it's, bothersome to them, and you'll just see it on clinical exam. So that's one of the most common cutaneous manifestations. And then you can have these papules. Other things that you can pick up on clinical exam is anterior uveitis. So you'll see like the conjunctival be very erythematous, and you could even see these conjunctival granulomas. So just something that you want to make sure that you look for on exam. Pulmonary involvement with sarcoidosis is in 90 to 95% of patients. So if you have a patient with sarcoid, more than likely they have some form of manifestation in the lungs. Most of the time they have this chronic cough that just won't go away. They have shortness of breath, vague chest discomfort, and wheezing. But it's not just hyalurodenopathy that pulmonary sarcoidosis can cause. It can actually cause pulmonary fibrosis, bronchiectasis. They can have these endobronchial sarcoid lesions, as you see here. It can cause some upper airway abnormalities or subglottic stenosis. And the lesions in the lungs can look like anything. They can be cavitary. They can look like pneumonia. They can look like, just faint little micronodules. So it's something that you want to explore if your patients are having a lot of different systemic symptoms. And it can also cause pulmonary hypertension. So as I mentioned, it can cause a lot of different changes in the lung parenchyma, and sarcoid is often called the great mimicker. And these are just some examples, but I mean, if you look up sarcoid and you look up the radiographic signs or manifestations of sarcoid, you'll see just about anything. Patients can get diagnosed with recurrent pneumonia, and it could actually be sarcoid. So just please always keep that in the back of your head. So you have one picture here where you have these micronodules that's kind of following along the airway. We see that as sarcoid. You have here just dense consolidative lesions that's in the right middle lobe that ended up being parenchymal infiltrative sarcoidosis. And then in this diagram at the bottom, you have fibrotic sarcoid, which is stage 4 sarcoidosis. So you want to make sure that you can pick up on these things pretty early, because it can advance to stage 4 and become fibrotic lung disease. So how can bronchoscopy be helpful in the diagnosis of sarcoid? We do bronchoscopy with endobronchial ultrasound. So the patient would be put to sleep, and we would go down and we have our bronchoscope with a balloon and an ultrasound at the tip. And then we stick our tools in there. We can see the lymph node in real time and do biopsies of it. This is actually a case that I did last week where I actually used navigational bronchoscopy to be able to get really distal to a lesion that looked like it could be pneumonia or cancer. And lo and behold, she had micronodules all around her airway, and it ended up being sarcoidosis. And with sarcoid, we look for non-caseating granulomas, which is what I had on the first slide. And that's granulomas that are just non-necrotic. If you have necrotic granulomas, you could see that with sarcoid, but you want to think more likely of an infectious process if it's necrotizing granulomas, like histoplasmosis. Okay, so take-home points for this case is there are other causes of mediastinal lymphadenopathy in addition to sarcoid, which you should explore in any young patient in their second or fourth decade of life with just generalized fatigue, joint aches, and cough. But infection, mostly fungal, smoking, it could be their manifestation of their interstitial lung disease. Heart failure can also cause mediastinal lymphadenopathy, and occupational exposures like beryllium, coal, asbestos, and silicosis. They can actually all look like sarcoid. Okay, and this is our last case, and they found a spot on my lung. So this, I really wanted to take home with incidental pulmonary nodules because we see them all the time, right? We get CT scans to work up abdominal pain and we see a left lower lung non-calcified nodule. What do we do with those? Well, incidental pulmonary nodules are nodules found incidentally on scans performed for unrelated reasons. And it's estimated that 1.1 million incidental pulmonary nodules each year are not appropriately followed up on. So it's really important. Since we launched our robotic bronchoscopy program, we are able to get to a lot of nodules that we weren't able to get to previously. And with our ion platform, it's a small, thin catheter, about 2 to 3 millimeters. We can get to anywhere in the chest wall into all 18 segments of the lungs. If your patient is referred for a navigational bronchoscopy for a nodule, for a mass, or for an infiltrate that we just can't make out, it is an outpatient procedure. It takes 20 to 90 minutes. And if it is a malignancy and we find that, not only can we diagnose it, but we can also stage them in the same procedure with that endobronchial ultrasound. So what we'll do is we'll finish the robotic portion, and then we'll take our endobronchial ultrasound, the same one that we use for sarcoid, and we look at the lymph nodes and we stage them. All right. So just some updates for you all. We have launched February 2023, and we've done at least 484 cases. I think we're not including in the past 30 days. Our pneumothorax rate is 2% because anytime you biopsy the lung, it's going to be a risk of the lung collapsing. It's only 2%, which is pretty good. And the diagnostic yield for all users, which is about 5 of us now, is almost 90%. So excellent results in getting patients answers. And these are just some examples of cases that we are able to get to that are quite difficult. As you can see here, you have an area that's really posterior, almost near the spine, and the ion is telling us exactly where to go. I tell patients it's just a $500,000 GPS, fancy GPS. I'm doing all the work. It just tells me where to go in the lungs turn for turn. And then here you have this faint area with my emoji there where it's, you almost, you have to look at the skin a couple of times to be able to see it because it's very faint. And some people may miss it, but that actually ended up being an adenocarcinoma of the lung. And we got it early stage and the patient was sent for surgical resection. These are more cases that sort of illustrates that we can go very far and very deep and, even go in places that you wouldn't think that the bronchoscope can go to. And that's like right on the pleura. So take home points for this talk. Always have interstitial lung disease on your differential on any patient who has diffuse interstitial process on imaging studies. Sometimes it's described as just pulmonary edema, but if patients are not getting better with diuretics, you want to make sure that you explore that as a possible etiology of their symptoms. Sarcoidosis is a multi-system inflammatory disease, and most times patients just present with a chronic cough. Other potential causes of hilar adenopathy that we mentioned heart failure, ILD, smoking, as well as some occupational exposures. And if you have an incidental pulmonary nodule, just refer it early. That way they can be established in our clinic and we can be able to get them the diagnostic workup that they need. And that's all I have for today. Thank you guys so much for joining me.
Thank you. That was really good. I don't see any questions from our participants at the moment, but I did write down a couple while you were presenting. So, how many pneumonia bouts per year or over the course of several years, how many recurrences would you say is too many where we need to probably think about a pulmonary intervention?
I would say two. I would say two a year. You know, a lot of our patients, because of where we are in Kentucky, where smoking is very high, they have a risk of cancer. And then also the fact that, you know, with the histoplasmosis being very high here, they could have some endobronchial component like the bronchiolithiasis. But if a patient has COPD and then they develop more than 2 episodes of pneumonia a year, or even if they don't have COPD, I would say 2 would be my threshold to get them seen by pulmonary, just because they could have something like sleep apnea that may be predisposing them to recurrent pneumonia, or they could have COPD or something in their airway, like we saw.
Okay. And then what is the difference in how you would both treat and monitor the incidental lung nodule that are noted on an abdominal CT or whatever, versus those that we see when we are truly lung screening for cancer?
So I think lung cancer screening, you mean like if you see incidental nodule on lung cancer screening versus if you were to see it on like a CT abdomen and pelvis?
Yeah, is there a difference when we know that they have the 30+ pack year history and they're in the right age range and they meet all the criteria for lung cancer screening, and so we put them through the low dose CT for lung cancer screening, then what's the difference in seeing an abnormality there versus something that we just truly weren't expecting in a lower risk patient?
Yeah, that's a really good question. I will say a lot of people that I have diagnosed with incidental nodules is probably a lot more than the lung cancer screening abnormalities found. And it's because a lot of people don't really follow up. So you may not really realize their risk factors until you see something on the incidental scan. And then you can so I get sometimes 30-year-olds, 40-year-olds that have no risk factors that just have these non-calcified like nodules that I think are granulomatous that will become granulomatous. What do you do with those? Well, I think, you have to risk stratify the patient. So if you have the incidental nodule and the patient's like a 35-year-old and it's really small, then I think, you really can give them the option to just not do anything if it's really less than 6 millimeters. But if the patient has risk factors, like I had a 43-year-old who his dad had cancer, his grandpop had cancer, and he had a 6 millimeter nodule and he was only 43. So I think that's a different patient where you want to make sure that you really risk stratify them and get them the follow-up 6 months or, a year. And maybe those are the patients that you're doing that peer-to-peer for if their insurance doesn't cover it. But if you get an abnormal screening CT, I think we probably all are going to be as aggressive based on the characteristics of the lesion. I don't think it necessarily means whether they got the screening CT and they have the 30 pack years or not. There are certain characteristics of these nodules that make us more concerned for malignancy than not. So I think it all depends on the size, the characteristics of the nodules, and the patient.
So we do have a question in the Q&A. So take, for example, the incidental nodule that you showed in your example in your case study. So what if on follow-up CT, it still showed that same nodule, but it was stable in size?
So this is probably an 8 millimeter nodule. I would still send it because it's probably, I think it would be best for them to be evaluated by our multidisciplinary team and be plugged in with us. I mean, unless the patient doesn't really want to see another provider. But if it's, I've had cases that I've biopsied that were stable, that were cancer, guys, because some of these cancers are very slow growing. And sometimes patients have granulomas within a cancer. So I think based on the size, I would say, I wouldn't necessarily based on it for stability. I think based on the size, if it's, 6 millimeters and stable, okay, maybe that's not a patient that you want to refer for evaluation. But I would say if it's 8 millimeters or above, even if it's stable, at least get an expert to look at it and see if it's of any concern and take it from there. The other thing that I think a lot of people forget about, and I tell this to my patients all the time, is some of them, especially the ones that don't meet criteria for lung cancer screening, when we keep getting these serial CT scans every 3 months or every 6 months, breast cancer is still one of the most common cause of cancers in women, if not the common cause of cancer in women. And that's a lot of radiation that they're getting with all these scans. It may be worth it to just biopsy it and prove that it's cancer or not, maybe granuloma, and they really may not even need all of these serial CT scans. So I would say if it's 8 millimeters or above, even if it's stable, at least get them to be evaluated just so that we could have some input and that they can be established within our practice in case it does change over time.
Okay, thank you. That's a great answer. So just to further elucidate, so 5 millimeters completely stable after a follow-up in 6 months or whatever your time interval is, you still say observation.
Yeah.
But based on size and appearance is when you push more towards the biopsy.
Yeah. And biopsy, with the robotic platform that we have, we are able to get to smaller lesions, but most of the time we are not biopsying 6 millimeter nodules unless we're biopsying something larger and it's just kind of there and we might as well just try to go after that one on the same procedure. But if it's just 1 6 millimeter nodule, no one's really biopsying those.
Okay.
It's really small.
I think that helps from a guidance perspective for anytime we see any of these incidental lomas, whether it's in the lungs or the liver or wherever else, it's a cause for concern because then it's something else for us to chase down. But having some threshold there for what to be concerned about and what to follow, I think is helpful.
Yeah.
I do not see any other questions, so I very much appreciate the information that you had today, and I think everybody got a lot out of this.